Hi, everyone. Thank you so much for joining us this afternoon for another Business Health Connect with Kelsey-Seybold. I'm Lane Galata. I'm a member of the marketing team here at Kelsey. I'll be your moderator for today's conversation and discussion with Kenneth Janis. Kenneth Janis has been with Kelsey-Seybold just over 25 years. He holds a MBA and an MHA, and his current role at Kelsey is our Chief Operating Officer. So, Kenneth, do you want to tell us a little bit about your journey over the 25 years at Kelsey before we hop into your presentation?
Most of my time has been spent in kind of the field of healthcare finance related to, the revenue cycle, capitation, risk, and analysis of the risk, and then more recently assumed the role of Chief Operating Officer here at Kelsey-Seybold.
So I'm going to go ahead and hand everything over to Kenneth.
Thank you, Lane. I appreciate the opportunity to share with you my thoughts on this topic and specifically understanding the capitation, the ACO model. Some of you may have had an opportunity to hear Dr. Carter back in November, about a month ago, on kind of the first of this series of the topics. And so I hope not to retread too much ground that he covered, but I hope to share with you my specific thoughts around capitation and kind of some of the practical effects and results of capitation that we've experienced here at Kelsey-Seybold. I want to encourage you, we planned the presentation to allow plenty of time for questions. And so as we go through the presentation, I encourage you to jot questions down. And I find it most helpful, to learn from the questions that I see from you all. So I appreciate and would welcome questions at the end of the presentation. I'm having some difficulty advancing the slides here. Okay, great. So again, our topic today is around capitation and focusing on some of the practical benefits and workings of a capitation arrangement for providers, and what generally employers should know about capitation. And looking at the attendee list, recognizing a number of names, and this will be a familiar topic if we spend any time together. But really wanting to just touch base on the practical implications of capitation, why we believe it's the most effective form of financing healthcare, and how capitation can achieve significant cost savings in delivering the triple aim, something that we refer to frequently here at Kelsey-Seybold around controlling the total cost of care, improving quality, and improving service. And it's my view, that those three things can coexist, and that we can manage down and contain total cost of care while improving service and quality. A couple of things that we'll talk about today, again, is what employers should generally know, why capitation is the most effective form of financing in healthcare, and some specific examples of how through alignment we can achieve savings through pursuing the triple aim. You'll hear this theme of alignment throughout my presentation today. I think it's because to me it's kind of key to the question of how healthcare should be financed. And if we think about in any parts of our respective organizations, anytime there's this misalignment between the strategy of the senior leadership in an organization and the interest of individual managers, employees within the company, when there's not full alignment, I think at best they won't reach their full potential, and at worst they're going to fail altogether. And I think somewhere in between, I think we tend to respond by trying to compensate for that, and we spend a lot of time and energy trying to compensate for what really is at a core is just misalignment. And the same is true in healthcare, where it's through this lack of alignment within the provider community, not just physicians, but hospitals and all of the ancillary providers, where their incentives aren't fully aligned with the employer. And so think the question is, how do we incentivize all of these individual components of healthcare, which is a very complex system, align their capabilities and their processes with the values and interests of employers who are, the primary financiers of healthcare, and of course the patient who's directly receiving the care and is also experiencing a growing financial burden. And so we'll talk about this in the context of capitation and fee-for-service. Dr. Carter shared I thought, an interesting view of fee-for-service in his presentation. I wanted to cover that. I thought, if we're going to contrast capitation to fee-for-service, we should give a fair shake to both. So there's certainly some advantages to fee-for-service. It's obviously the dominant form of the way that healthcare is financed today. And there's certainly some admirable qualities about it. One, it certainly rewards physicians, providers of all likes for hard work and earned hours spent on delivering great patient care. And so it's reassuring you know that services that you provide you'll be paid for. It promotes good patient satisfaction and access. I mean, we're in a free market economy, and to the extent that providers and organizations want to see their volumes and their organizations grow, they'll be focused on service and quality. I think fee-for-service, the incentives of fee-for-service promote the use of new technology and new drugs through innovation, and certainly to the extent that they're successful, those organizations will profit from that. I think the question is whether or not that new technology or new drugs are effective and efficient, but certainly it does promote the development of new technologies. Fee-for-service is typically offered, although not always, in a much more broader, probably less narrowed network arrangement. And so it provides, I think, additional freedom to both physicians and patients to operate in that environment. And then, to the extent that providers are successful in delivering, good service and care, they have a good means of earning a good compensation. So I think those are certainly some advantages of fee-for-service. I'd say the two big areas of disadvantages, which we'll focus on in contrast to capitation, is really around overutilization. I think it's pretty well established now, both the direction that Medicare has taken and a number of initiatives through the traditional carriers, that fee-for-service induces overutilization amongst providers. It's just inherent in how the system works. And that, in addition to overutilization, it also incentivizes providers to provide care in with higher margin services without necessarily there being an indication to. And so on one hand, it promotes, incentivizes overutilization. Probably equally as important is it doesn't reward behavior that would help control costs. And so Dr. Carter, I think, mentioned in his presentation, there's no CPT code for avoiding admission or avoiding a series of tests that may be borderline effective. And there's certainly no way to be paid for kind of innovating ways to conserve care. The way that the health system works today is being paid for things that are done, not investing in creating ways to provide that care more efficiently. There's certainly some alternatives to fee-for-service, which I think all four of these, starting on the left, are admirable and do a great deal to try to dampen the perverse incentives of fee-for-service. But I think that overall, I think they fall short of reaching the full potential of capitation in global risk. So, making the case for capitation, and basically it effectively aligns the doctor, the patient, and the employer. I think, although not perfectly, I think it aligns them more fully than any other form of payment, and certainly more than fee-for-service. It promotes the efficient use of resources based on value, not volume. I'm sure we're all have heard the theme of moving from volume to value. And I think it's capitation that allows that to happen just organically. And I'll share with you some specific examples of how that has occurred at Kelsey-Seybold. I believe it facilitates the use of standardized quality metrics in a capitated environment where you have patients that are typically assigned to you for some extended period of time. I think it allows providers in the ACO organizations to better rely on quality data as opposed to in a fee-for-service environment where members may come to you for a part or even a small part of your care. The quality of the data that you're provided and measured against is less reliable. I think it also increases the emphasis on delivering outstanding service. And so to the extent that a provider organization that is accepting capitation and is responsible for the full care of the member is required to provide outstanding service for that member will find care elsewhere. And finally, it promotes transparency and accountability. We'll talk more about that in detail. So basic capitation definition, which I'm sure many of you are familiar with, which is simply a fixed payment on a per member per month basis for a defined set of services. So the healthcare, that capitation rate is intended to represent kind of the average cost for population. And those capitation rates are typically adjusted on an age, gender basis when paying the physician. Some key components of professional capitation that we refer to and are just part of the vernacular for a provider dealing with the payers. One is a DOFR, or Division of Financial Responsibility. And so as you evaluate ACOs, those ACOs or provider organizations have in their contracts with payers this Division of Financial Responsibility that very specifically lays out the services that they're responsible for. In many cases, that's at a CPT code level, but it's also more general in terms of whether or not that includes and disease management. As part of that DOFR and the responsibility that comes with managing that care, payers or providers are often delegated for claims payment. They're delegated for utilization management, and in some cases delegated for disease management. All of these are typical health plan functions, but as part of the responsibility of accepting capitation, what we have found at Kelsey-Seybold is they offer a tremendous amount of insight into how that healthcare dollar is spent, and so being not only at risk for those dollars, but having to process those claims and be delegated for utilization management brings us much closer to working through and finding ways to improve the healthcare system. And of course, the development of an affiliate network, which typically surrounds the base provider network to provide services maybe that aren't offered by the primary care or the specialty network that's receiving the capitation rate. So putting the A in the ACO. So this is in my view, in terms of the health system today, I think the question is, in making the case for capitation, is who ultimately is accountable in today's healthcare system and in terms of controlling total healthcare costs. Is it the purchaser? Is it the payer and the broker, the benefit manager? Is it the patient who's self-directing their care? Is it the providers, whether the hospitals or the providers? I think the second question is who is best positioned, to bring order and predictability into our system of healthcare, which today is made up of a bunch of individual organizations kind of doing the best that they can, but serving their self-interest and fragmented and not well coordinated. And then the secondary question is, and then how to pay them. And so who's responsible, and then how best to pay them to incentivize them to organize and have enough incentive to take on the task of organizing all of these components of the healthcare dollar. So I think while we've created this term ACO, Accountable Care Organization, in the market, I think in many cases it's a name only. My personal belief is that without real kind of healthcare finance reform or a version of capitation that fully incentivizes a provider group or an ACO to manage and be fully accountable for organizing this care, then it's simply a new name to an old system. And so it's our belief that providers are best positioned to control and to best organize the delivery of care, and whether that's a full ACO or provider physician-driven organization. We believe that providers are in the best position. We also believe that because physicians are responsible ultimately for what's estimated to be anywhere between as high as 85% of medical costs, that that through their ordering of services, that they're best positioned again to organize a system of care. And ultimately, we believe it's the physicians who drive the bulk of the care. And so, how does capitation incentivize and align the provider? We believe, I believe that essentially it's the fuel of innovation for our organization. It creates this exciting environment within Kelsey-Seybold and other organizations that we've spoken to that accept capitation. That first of all, it detaches them from these perverse incentives and administrative burdens of fee-for-service. So, for example, and within our organization, when we look at our revenue cycle organization versus our pop health, today Kelsey-Seybold is about 60% capitated. Of our visits are capitated, and the other 40% are fee-for-service. And so we live in both worlds, but we do our best to act in a value-based way across all lines of business. But there's necessities and business functions that are required under a fee-for-service environment. And so just to contrast those in the CBO, our central billing office, or revenue cycle, we're constantly having discussions about pre-auths for surgery, radiology, medical necessity denials, claims edits, versus the conversations that happen in the context of capitation on our population health team are about how do we better manage frequent ER utilizers, or how do we get our diabetic patients in who are on an A1C outlier report, or high cost claimants. And so it's how we decide to deploy those resources. One really out of a necessity on fee-for-service is very different under fee-for-service than capitation. And really it comes down to the idea of, are we chasing payments? Are we chasing outcomes? And we'd much prefer to invest our resources in those functions that add value and promote health and good outcomes for our patients. I think it also focuses the organization finding new ways to create value. So site of care initiatives are a constant topic within our organization. How do we move patients from a high cost inpatient setting to an outpatient setting, to a clinic setting, and even possibly down to a home or virtual setting, if that's convenient to them? How do you do that when it's clinically appropriate and as effective with the same level of quality? But those are conversations that are frequently had within our organization. An example of that recently occurred, this has been a little over a year ago, maybe 2 years now, where we had a physician who was able to do carpal tunnel surgery in an office setting. Those surgeries were previously being done in our outpatient surgery center. We were doing those for both capitation and fee-for-service. It was a source of revenue for our ambulatory surgery center. And then when we developed the capability to provide and to perform that surgery in an office setting, really without hesitation, we purchased the equipment and moved that service into an office setting. And that's just an example of the commitment of an organization's in a capitated environment, to pursue value and total cost of care, as opposed to individual revenue or margin associated with a volume. And as an organization, I think capitation has really helped us to laser focus on other opportunities in that cost continuum that we could continue to move down to more efficient costs of care. The other thing that it's done for us, and this has really been highlighted in the time of the pandemic, is it allows us to more easily and quickly deploy resources to pursue the triple aim. So we're less worried about, in the capitation, we're less worried about whether we'll be paid for a specific service or how we'll be paid, or even, quite frankly, how we're going to pay the provider internally under a capitated environment. And so, our ability to explore and innovate around virtual health have been a great benefit to us, and we believe our capitated patients. Pre-pandemic, we had efforts to to promote virtual health more broadly, we're fairly limited in the extent that we could deploy that across the organization, because as an industry, virtual health wasn't reimbursed, on a fee-for-service basis beyond the direct arrangements that employers may have had. But within our capitated book, we had the freedom to do that, and we're beginning to see, good progress. And certainly the pandemic has accelerated that a great deal. But I don't believe we'd have been in the position that we were in if we hadn't have had our capitated book of business to begin to develop our virtual health capabilities before the pandemic. E-visits is another great example of a way that we've been able to explore and develop new ways of offering care. So e-visit you can think of as a electronic hallway consult. It's a standardized way for our primary care physicians to converse with and consult with specialists on a fairly quick basis. Our primary care physicians will submit an e-visit request or an e-consult to a specialist. It goes into a pool that's continuously monitored, and so they get a quick response. And it's estimated that today we're doing about roughly 600 of these e-consults a month, and it's estimated that roughly half of those are avoiding an additional specialty visit altogether, or avoiding unnecessary radiology testing by a primary care physician. So again, just another example within our organization, how capitation has given us the freedom and the incentive to explore those options. I will say that though even an organization like Kelsey-Seybold that I would describe as pretty far along this continuum of managed care and coordinated care, it's still an effort for us living in both this fee-for-service and capitated world. We need to stay vigilant in continuing to pursue the value over volume. And so we have a number of initiatives internally, as I think other capitated institutions do, to ensure that that value is trumping volume throughout practices. So as new physicians, new leaders within the organization join us, that they understand the culture and how best to deliver care through our system. So practically, where are the big buckets of savings from capitation, and how is it manifests itself to an employer? I would say these are 4 categories that are we could spend more than half the presentation just on this particular slide, but site of care is probably one of the significant areas as we move procedures again out of an inpatient setting and into either an outpatient hospital or freestanding ASC, reduces costs to the employer. I think joint replacements are an area that you'll be seeing in the near future. We'll be moving more to an outpatient, at least an outpatient hospital basis. It's not at some point standing facility. In a capitated environment, there's limited out of network because of just this kind of inherent plan design around capitation. I think what we experience is an out of network experience of maybe 1 or 2%, and that's really predominantly limited, if not exclusively limited, to ER use. And so because we're capitated, or an organization like ours is capitated, we're also exposed to out-of-network fees for providers, just like an employer would be exposed to the out-of-network charges for facilities or ancillary providers. And so we're fully aligned in that regard to limit out-of-network usage whenever possible. We spend, again, capitation because it allows us to focus on total cost of care, encourages us to focus on areas that we're not even at risk for. So generic prescriptions and formulary compliance are areas where we invest time and energy to ensure that we're delivering the most cost-effective medicines and complying best to our ability with an employer's formulary, so that the employee is receiving the best value as well as the employer. And then utilization, which is a broad category, but overall, I think Dr. Carter had shared in his previous presentation that generally we see savings of anywhere between 15 to 30% when this capitated model is deployed to employers. And typically it manifests itself in 3 significant utilization buckets, and that's roughly a 30% reduction in ER visits per thousand, but a 34% reduction in admits per thousand. And one of the areas that's not thought of as much is around catastrophic claimants, where we'll typically see a difference as much as 62% reduction in the number of catastrophic claimants per thousand in our population than in a comparable population within a specific employer. So one of the questions I receive a good deal is, that, well, capitation or fee-for-service may have its disadvantages, but capitation is a black box. And how do I know what I'm getting? And I would say generally in today that capitation shouldn't be a black box. And this is not, your 1990s or 1980s HMO. I think technology has taken us a long way. I think certainly our payer partners that we've worked with have invested a great deal in not only technology, but in the relationships with organizations like Kelsey-Seybold to ensure that that there's transparency in reporting of encounter data. And so what should you expect from a capitated provider? One, I think you should expect data. And that's all of the data. And that includes, we're proud to say that in our relationships with our employers, we provide 100% of the encounter data. We provide that to all of our payer partners who capitate us. And for our large employer clients, we provide that encounter data to them directly, with the appropriate BAAs and non-disclosure agreements. So it should be transparent. Routine reporting regarding quality and performance should be expected. We at Kelsey-Seybold have developed specific employer reports that are specific to employers that we're happy to share with our payer partners to incorporate into whether it's monthly or quarterly. Typically, it's quarterly reporting back to the employer. And there should be metrics around service. And so it's great if we're controlling cost and we're improving quality, but the employer should also have an indication of how their employees are interacting and their perception of their interactions with the capitated provider. And so I think you should expect information around customer service that's specific to your population. You should also expect information in terms of how the ACO is effective at effectively managing costs for your population. Again, our experience in working with our employer partners and our payer partners is that this data is available, and it's worth our time and effort to invest in improving those reports so that employer partners can see how we're managing the population in specific cost categories. In the industry, in any arrangement, there's certainly, in our case, there's always room for improvement, and we think the best way to capture that improvement is in a partnership with our payer and employer partners. And in many cases, that starts with reporting to identify where those area improvements are. And so the main theme is, again, is that this isn't your 1980s HMO. I think, again, through the technology and through information systems, you should expect a good deal more with regard to reporting from not only your ACOs, but from those who are capitated. Capitation shouldn't result in reduced reporting requirements from an ACO. So the future is now. We do believe that capitation is the future of healthcare financing. There's certainly some efforts needed to help this scale. In our conversations, we've been approached over the past year by a number of organizations who are interested in moving in this organization, who maybe had these capabilities, earlier in the decade and or in the 2000s, and kind of abandoned them because of fee-for-service, but are interested in pursuing them again. And then certainly, if our payer partners are any indication, we've added our third co-branded product with Humana this year. And so we now have Cigna, Aetna, and Humana as co-branded capitated products. And I think there's more interest and enthusiasm around attempting to have capitation scale in the market. And again, our view is that the future is based on data and continued interest. is based on continuing payer partners like Humana, is the latest collaborator. But through this interest, I think it'll grow, and we personally believe that in our market, if there are more provider organizations that can accept capitation, that this will help our payer partners scale it in our marketplace. So with that, I think we met our time target, and happy to take questions from the audience.
So we did have a few questions that came in during your presentation. The first question, is it possible in the Kelsey-Seybold delivery model to integrate professional capitation with episodes of care, especially for chronic condition management?
Yeah, good question. You know, we've I wouldn't say that it's not possible. I know we've had conversations with various organizations that that were promoting kind of episodes of care payments. I think our question internally has been whether or not that's additive or not within the capitation model, or if that's kind of duplicative of what's already occurring. So I wouldn't say it's not possible. My question may be, would it be necessary and additive to what's already occurring?
And another question that came in was about involving patients or consumers in their healthcare. They want more involvement in their healthcare decisions. So in a capitated environment, how do you balance patient expectation and the responsibility for care, which we highlighted?
Right. So I think what our physicians would tell you is that patient engagement is absolutely necessary. I described earlier that the kind of putting the physician at kind of the head, or the provider at the head of the ACO, and probably a better illustration of that is having the physician and the patient as kind of owning that relationship. And so patient engagement is essential to us being able to the provider being able to effectively deliver care. One of the things I think Dr. Carter may have mentioned in his session we talk about frequently is through our population health efforts and disease management, case management. One of the difficulties that we have many times in being able to fully control total cost of care is patient engagement, whether it's patients not returning calls or not being receptive to to our outreach. I think we were able to do a better job given that we're coming from the provider, but still there's there can be pockets of resistance. I think one of the goals within Kelsey-Seybold, at least, I think this is maybe as much a function as a multi-specialty provider group, but I think the electronic medical record, having that information available at patients' fingertips is certainly helpful in getting them engaged in their healthcare.
So let's talk a little bit about health plan structure. Does health plan structure, the capitation, set up the system to pay both the capitated and the non-capitated plan expenses?
Yes. And so in our typical arrangements and those that are on the screen, the health plan, the medical group is contracted directly with the health plan on the capitated basis. And so the health plan will pay us our capitation based on those members that are assigned to us. And then for those non-capitated services, the health plan serves as the TPA, or the claims payment function for all of those services. And I think that's one of the reasons, I may have failed to mention this earlier, that capitation, another question I receive is, does capitation work in a self-funded environment? Because self-funded employers are typically, they're very interested in managing their cost, and to the extent that they save money, they keep those savings to them, within the organization, which I think we're a self-funded employer as well. And I think what capitation allows us to do is, as the provider organization, to partner with the employer in the sense that the capitated services represent somewhere between 40 to 50% of the total medical cost dollar. And so to the extent that the provider can control the total cost of care, all of those services that are quote unquote self-funded and paid by the payer, to the extent that services aren't utilized, like admissions or outpatient surgeries or ER visits, that full benefit, 100% of that savings accrues to the employer in a self-funded arrangement.
So let's talk about specific types of services. Does Kelsey request that specific types of services be within capitation? Specifically, what about behavioral health?
Right. Yep. So in general, in our arrangements, the major categories of services that are included under capitation are all physician services. So think of anything that's provided by a physician or that's billed for the techie, the folks that are really into healthcare, those that are billed on a HCFA 1500. Then all ancillary services, so all radiology and lab and diagnostic services are covered under capitation. Those are the two major buckets, as well as physical therapy and occupational therapy. Behavioral therapy, mental health are typically not covered under capitation. I would say that's less about what our capabilities are, and it's more about those are functions that have historically been, through separate networks that the payers manage.
So let's talk a little bit about growth. What is Kelsey-Seybold's plan towards expansion of the capitated approach into other markets?
Right. Well, certainly Houston is a key focus of ours today. And as I mentioned, we continue to build great relationships with our payer partners around our capitated products and those that are co-branded. We think we continue to see success. I think we've had on average growth of about 10% membership growth in our capitated products per year, which we think is very strong. I think probably one of the rate limiting factors really is around education, is that helping employers understand the benefits of capitation and how it can really change the dynamic in terms of how healthcare is delivered. So I think we see a great potential in the coming years, both through better education of employers through means like this, but also with our payer partners who I think have found and have seen the results, through the products that they've administered, that there's true and sustained savings through this type of model.
So we have lots of great questions that keep coming in. Another one is that you mentioned that we have that constant monitoring of data for possible improvement, here at Kelsey. Do we have any examples of how we were able to improve outcomes and lower costs based on Kelsey's advanced data analytics?
Yep. So there are a number of things that Dr. Carter may have touched on. This is a great question for our physicians, because this happens throughout the organization. But in the context of Pop Health, we're monitoring A1C levels for diabetics, identifying those that are outside of range, monitoring patients that are high ER utilizers and getting them in touch with our population health team. We continue to build out our capabilities around population health, in moving more from the telephonic, singular telephonic approach to more a home-based approach. So we are developing the capabilities and now have the capabilities to go out to someone's home if necessary, or connect with them virtually. So for us, it's a matter of investing in ways that kind of remove any barrier, real or perceived barriers by the patient to receive care within Kelsey-Seybold. I think the areas around pharmacy are areas that we're proud of and have been very data-based. So we have a number of programs where we feed pharmacy data into our system to understand adherence and whether or not patients are on their drugs. And I mean, it's one thing for our providers to know that they prescribe the drug, but it's even more important to understand whether the patients are filling the drugs. And so incorporating that adherence data into our EMR allows our providers just a whole nother set of a whole nother view in terms of the behavior of the patient. And so I think that's an area that's helped us achieve not just savings in moving to more generics, but in improving adherence measure for our patients.
So the growth seems to be a quite popular topic coming in with the questions we're receiving. Um, Regarding ACOs, are we seeing growth across the country with interest in ACOs and capitation models of healthcare?
Right. So, my view on this is really formed by the conversations that we've had with our payer partners and their capabilities. And so to the extent, what investments are they making in capitation in their claim systems around, being able to pay and develop capitated models. And we see that interest growing. We fielded, I mentioned, we fielded a number of calls over this past year from groups throughout the country who've heard of our story and have been inquiring, basically, how did we make the transition more fully from fee-for-service to capitation? And then, some more detailed questions about, how do you set the capitation rates? How do you, how did you work with the payer to develop a product that was capitated? And more around the lines of how did we make that transition into developing, what they've come to know as these co-banding products of that we refer to as Kelsey-Care. So I can't speak to, I don't have any specific numbers in terms of, how many of these plans are being adopted, by employers throughout the country, but just that I think there's growing interest from our payer partners on this topic.
Another question that came in was about contacting Kelsey. Can employers contact Kelsey or contract directly with Kelsey, or do they need to go through Aetna, Cigna, or Humana?
Yep. So our arrangement today are through our payer partners. So we don't contract directly with any employers in this model today. But we really partnered, and we think it's important that our payer partners have added real value. There are some services that not only our organization but other groups that may take capitation services that they don't provide. And so while we have a number of disease management programs, we don't have the full menu of disease management programs. And so, like smoking cessation is one that comes to mind that we may not have here, but that a payer may include as part of their disease management package. So I think the other thing is we worked hard to try to complement and add to the payer reporting package through our data. And there's reporting capabilities that report more broadly on the cost of care that we haven't invested in that our payer partners have.
All right, so let's see. We still have lots of great questions coming in. The next one is payers had a different kind of pandemic because they collected premium dollars but didn't have to pay for care during the pandemic. Are they going to invest that back into ACOs? And with that money, how will that impact capitation arrangements?
So we certainly, I can speak to Kelsey's experience, and have certainly heard and read the articles, mainly around Medicare Advantage and kind of fully insured, where the care was deferred and not provided at the levels that it normally had been provided, especially in those peak months of COVID in the early spring and really through the summer. So I've heard firsthand of examples of where payers are investing those dollars back into the system. To me, I think the question that's still outstanding is kind of we need to make our way through COVID and understand what are the downstream effects of care that's deferred. Certainly things like ER visits we saw a decline in. We saw some decline in our office visits within our organization. But I think the bigger question is what impact did that have to the long-term health of our patient population? And so we're working, we're eager to have those patients continue to engage with their physician. We've continued to see patients throughout the pandemic, actually fully through the pandemic. But we do believe that there was some care that was deferred earlier in the year and maybe continue to be deferred. And when that will re-arrive, I think it's a matter of waiting and seeing.
So let's
So I don't know if I fully answered that question, but happy to answer a follow-up question on that topic.
So let's talk a little bit about results. You've been doing this for quite a while now. Do you see economic results for the clients that you work with?
Yeah, absolutely. I didn't share a lot of data with you today, just in the interest of time, but happy to do that, as requested. So we have over a decade worth of data around the efficiency and effectiveness of capitation. I would say in general, many of you may have heard that we project anywhere between 15 to 30% savings in our Kelsey-Care capitated products.
So let's talk a little bit about capitation rates. Can you explain why they are so different across accounts?
Sure. So one of the aspects of Kelsey-Seybold, and this may be unique to us as opposed to kind of an industry standard, but in the old days, capitation was priced really kind of at this fixed age sex table. So you can think back to the 90s and early 2000s, it was just one fixed table that maybe varied based on the copay level. And regardless of the mix of those members that chose your plan, it was it was a fixed age sex table. One of the things that we've done differently with our payer partners is develop employer-specific capitation rates. And so our payer partners provide us the high-level claims and projection data that we then use to develop the capitation rate. We then provide that capitation rate back to our payer partner, who then loads it, and that's the rate that's paid for that particular employer for that particular year. And so one of the reasons that they're different is because the utilization for any given employer is different. Their benefit design, their cost share can be different, but more importantly, just the makeup of that employer group, could vary significantly. And so our goal is to try to develop capitation rates that best mirror and represent that individual employer, as opposed to having a pooled rate where the rate may be higher for some or too low for others.
Wonderful. Let's see if we have any other questions that came in. I think we have one. Yes, we have one more that just came in. Can you mention a few of the affiliate partners that you mentioned earlier in the presentation? How does Kelsey ensure that when patients do need IP or OP procedures at hospitals, they're getting the best care at the best cost, since it's not included in the capitation?
Right. Yeah, good question. So, I think one of the things that capitation does is it really focuses the organization not just on the care that they're at risk for, but on the total cost of care. And the reason for that is because if you're competing in the marketplace on a capitation rate and you need X number of dollars, you believe, as a capitation rate, and you don't mind the shop on the total cost of care, at some point there's just not enough dollar to go around. And so I think inherent in this capitation model is this incentive to manage the total cost of care. Because to the extent that you can do that, then the capitation rate is sufficient enough to invest in the delivery of care that will allow us to continue to lower cost and improve quality. So I think those two things are related.
Wonderful. I don't think we have any other questions that have come in, so we'll give it just a minute to see if we have any other questions. But Kenneth, did you want to leave us with any closing remarks before we start wrapping up for today?
No, I just close. I greatly appreciate everyone's time and certainly appreciate the thoughtful questions that came through, and we're certainly happy and available to answer more as people have time to think about it.
Again, thank you everyone who tuned in. And if you have any other questions about the ACO model, please reach out to us. We have a whole team here prepared to answer all of your questions. And you can also view more information on the webpage, kelseycare.com. So thank you again to everyone, and we hope you will join us for another Business Health Connect